to the STEP Learning Collaborative Provider Training Series. My name is Josina James. I'm a clinical social worker here at the STEP Clinic and the Director of Social Work for the STEP Learning Collaborative. As most of you know, the STEP Learning Collaborative focuses on creating a system of care that transforms access and care quality for individuals experiencing a first episode of psychosis in the state. But today, we want to make an opportunity to provide education and resources that are available for those individuals who may be experiencing clinical high risk for psychosis, or what we would call prodromal psychosis. We are thrilled to have our speaker, Dr. Emily Farina from the Prime Clinic, with us today to discuss clinical high risk for psychosis. So thanks for joining us today, Emily. Just a bit of background on Dr. Farina. She is an instructor in the Department of Psychiatry at the Yale School of Medicine and a clinical psychologist at Prime, which is a clinic and research program for individuals at risk for developing a serious mental illness. Dr. Farina has extensive training and experience working with individuals across the schizophrenia spectrum, and she has specific expertise in assessment, treatment, and education in the area of clinical high risk, or CHR, for psychosis. In her current role, Dr. Farina engages in a combination of direct clinical care, research, and education and consultation related to CHR. So without further ado, Dr. Farina, I will hand it over to you.
Thank you so much, Josina. Hi, everyone. Glad to be here today and talk with you all about, as Josina mentioned, identification and treatment of youth at clinical high risk for psychosis. So today I'm going to be focusing on this topic here and really trying to help distinguish us from the great work that's being done at STEP and through MindMap. So what we'll talk about today is I'll start with some information about Prime, who we are, what we do. Then we'll dive into what it means to be at clinical high risk for psychosis and what it can look like for some youth who are experiencing this. And then finally, I'll go over what to do when you recognize a young person who may be experiencing some of these signs, including possibly how to refer them to a specialized evaluation and for care. So as Josina mentioned, I'm a clinical psychologist at the Prime Clinic. Our team at the Prime Clinic includes psychiatrists, psychologists, social workers, and research staff. Our overall mission is to identify, treat, and study the symptoms that put someone at a higher risk of developing a psychotic disorder like schizophrenia. And we do this through a variety of different kinds of projects. So we were primarily a research clinic out of Yale for about 25 years now, and we're housed within the Community Mental Health Center in New Haven. In 2018, with support from SAMHSA, we also moved into providing direct clinical care for young people who are deemed at clinical high risk for developing psychosis. So in addition to research and treatment, we also conduct psychological assessments. We do outreach and education in the community to train providers. We also talk with school systems as well as the families of young people. So I think before we can talk about what it means to be at clinical high risk for psychosis, I think it's important to cover a little background on what psychosis is. I'm sure many of you have already learned a lot of this information through work with STEP or coming to some of these learning collaborative presentations. But for anyone that is new today, we'll catch you up to speed briefly. Psychosis refers to when a person is kind of out of touch with reality, or they may have a distorted sense of reality. So really, I think about this as they may not be perceiving or understanding the world the same way as others do around them. So for example, they may experience things like hallucinations, seeing or hearing things that other people don't. They may experience delusions, which are generally inaccurate beliefs. So these beliefs could be bizarre. They could be feeling like aliens or the FBI are tracking you or implanted a chip in your head. But they could also be less bizarre or not bizarre, but still not true. So things like my partner's being unfaithful to me. Some people also show symptoms such as disorganized speech or behavior. So this usually shows up like when you're trying to communicate with a person and it's just really hard to understand what they're saying. Say there's no language barrier, but it's just hard. They're not getting their point across. They're kind of tangential. They're going off track a lot, and they really can't kind of orient their speech around a goal. So people with psychosis may also experience other kinds of symptoms that are not these kind of primary symptoms. They may also experience negative symptoms, so things like reduced motivation, not having the same emotional expression they used to have, and also maybe social withdrawal. They may also show some cognitive changes, so things like trouble thinking clearly and paying attention to information. So as you're all probably already aware, psychosis can be associated with a variety of adverse outcomes for the individual, for their families and caregivers, and for society and the world at large. These include things like frequent hospitalization and other kinds of service use, increased risk of suicide, substance use, and homelessness, and also financial strain, to name a few. So you may recognize this slide if you've been to other Learning Collaborative presentations. But in early detection and intervention work, we want to either prevent or reduce the impact of those adverse outcomes. Broadly, we do this by identifying people early in their illness and getting them into care. So what you see on this graph here is the typical course of schizophrenia across the lifespan. Now, no experience of psychosis is the same, but we do see a typical course of symptoms throughout the lifespan. So in those early years, kind of childhood or maybe very early adolescence, no symptoms may be present, functioning may be fine. If symptoms are present, they're really usually not noticeable. People are functioning generally well. Then in the early adolescence to young adulthood range, we'll say 12 to 25, 12 to 30, some of those emerging symptoms may start to show. They may be kind of sub-threshold, sort of subtle, not noticeable to many people. And you see that range here in yellow. Call that the prodromal stage. And then finally, in red here, you can see that first episode period indicated by this really kind of large and relatively sharp drop in functioning and onset of symptoms. So that's where the work of like STEP and Mind Map and other first episode services are doing this incredible work. They've shown that if you intervene early in that time, you can reduce and prevent a variety of adverse outcomes and really help those individuals retain their functioning. So at the Prime Clinic, we do something a little bit different than that. And we ask, can we identify people even before that time, before someone has a first episode? We work in this range here when someone's experiencing a potential prodrome. Now, if you haven't heard of a prodrome before, I'll show you what this looks like. So prodrome is actually a common medical term. It's used to refer to the nonspecific signs and symptoms that occur in some condition before the full onset of that condition or disease. So for example, I'll use COVID as an example, since I think everybody is probably familiar with that at this point. So let's say on Wednesday morning, you wake up and you cannot get out of bed. You have a headache, body aches, you're feverish. You take a COVID test, it's positive, and you have that condition, right? You have COVID at that point. So let's say you call your doctor and you say, I tested positive, I have these symptoms. The doctor might ask you, when did those symptoms start? When do you think this all began? And you recall that on Monday, you had this kind of mild headache, but you didn't realize at the time that it was those symptoms until they became more severe. So that period between Monday and Wednesday would be a prodrome. So it's those early warning signs and symptoms before the full onset of a condition. We can apply that same idea to psychosis. So you can take a group of people who experience a first episode of psychosis, and then you ask them, what has your life been like over the past few years? And many of those, the vast majority actually, will describe changes in their experiences over the couple of years prior. Oftentimes they report things like changes in their social functioning or changes in the way things look or sound. So that is what we would consider to be the prodrome. So I'm going to try to show you a video that's publicly available on YouTube. It was created by Origin, a group out of Australia. And in this video, what you're going to see is two friends. One ultimately develops a first episode of psychosis, and you'll watch, his name is Joe. You'll watch Joe's symptoms escalate in a not uncommon way. So he'll go from experiencing what we call attenuated or kind of less severe symptoms that are not necessarily like psychosis yet, to full-blown symptoms. He's being convinced that these things are true and it's really affecting his functioning. So I want you, as you watch this, try to think to yourself at what point you would recognize something is going on here, and would you feel comfortable referring him for an evaluation?
This is Joe and Charlie. They've been good mates for a while. Actually, best mates. They spend most of their time gaming, and then usually end up outside when they've had enough of Ginger's barking. But their journey hasn't always been easy, especially when Joe was struggling with his mental health and started to experience psychosis. The first things he noticed was feeling disconnected, as though the world was moving too quickly around him. The more he tried to make sense of this, the more he felt confused and overwhelmed. All the things Joe used to enjoy became too stressful, and he felt more and more isolated. Everything looked out of place. Everything seemed too hard. Even the simple things were too much. Joe felt like giving up. After a couple of days without sleeping or eating properly, Joe's perception of reality started to change. He became preoccupied with searching the internet, trying to find a way to feel better. As Joe spent more and more time on his computer, he became convinced that everything had a personal message for him. News articles and ads featured his name and seemed to know all about him. At the same time, he started to notice messages and alerts on his phone from people worrying about him. It was hard to understand what was real and what wasn't.
You're lost, aren't you, Joe? You're hopeless, Joe. You need to figure this out for yourself, Joe. You can't trust anyone else.
The voice became relentless, and Joe believed it to be real. He no longer trusted himself or others. But he realised he couldn't cope on his own. With Charlie's help, Joe was able to seek mental health support. Joe was diagnosed with psychosis. He began to receive appropriate care with the support of his family and friends. Joe realised that recovery was not a straightforward process. It takes time and perseverance. But it wasn't as daunting as he thought, because he wasn't alone. An essential part of Joe's recovery was learning new skills with Charlie. He began to feel more confident and hopeful for the future. Joe had found his balance again. This is Joe and Charlie. They've been good mates for a while. Actually, best mates. One of them experienced psychosis.
As you probably saw in that video, since Joe did experience a first episode of psychosis, we can pretty confidently say that those early symptoms he showed before he was really convinced and really perceiving like differences in reality, that those early symptoms were a prodrome. That's what we could call it at that point. But at Prime, we want to identify people before they even experience that first episode. So when we do this prospectively, without knowing for sure whether someone will ultimately develop psychosis, we refer to it as clinical high risk for psychosis, also called CHR or CHRP, or even more recently, CHIRP. So now imagine, what would it be like if we could identify youth like Joe in this clinical high risk phase and then get them into care before that first episode even hits? So it turns out we can. Doctors at Prime have written a book on it called the Psychosis Risk Syndrome. You see that here. And they also developed an evaluation a few decades ago now that allow us to identify young people experiencing these emerging symptoms as they're actively unfolding. So the evaluation is called the SIPS. The SIPS is a well-validated instrument that's used internationally. And for anyone familiar with or who uses the DSM, this has also been included as a category in the most recent version of the DSM called attenuated psychosis syndrome. Yep, you can see that here. And research has found that when we use this evaluation and we identify people in this way, around a quarter of them will develop psychosis within the next 2 years. And of those who do not end up going to develop psychosis, many will go on to have some longer-term symptoms or challenges with functioning. And so to address those symptoms, specialized treatment programs have been developed actually across the world, including at Prime. And the main goal of these programs are both to reduce the duration of untreated psychosis, so get people into care even before psychosis develops, and to help reduce symptoms and improve functioning in these youth currently, so the current challenges that they're facing. So people come to Prime through a variety of different kinds of referral sources. Sometimes they learn about us, they refer themselves, but most often they are recognized by a medical or a mental health professional, and then they're referred to us. Since there are a few medical and mental health professionals in the attendees here, I'd like to show you some of the signs that you might be able to look for that may indicate a person is a good fit for an evaluation. So these are the kinds of things that you can look for on the outside, what a young person might be showing. So importantly, if you observe these signs in a young person, you want to notice whether those are relative changes for that person. So some of the big ones that we notice here are having increased difficulty at school or work. Again, relative changes for that person. If this is someone who was always kind of a C/D student, we're less concerned if they still are. But if they used to be an A/B student and now all of a sudden they're kind of a D/F student, that's really concerning to us. If they have withdrawal from friends and family, difficulty concentrating or thinking clearly, a new suspiciousness or mistrust of others when it's really kind of not warranted and there's no reason for them to have that. Changes in the way things look or sound, odd thinking or behavior, emotional outbursts, lack of emotion, or really just changes in how they experience their emotions. Poor personal hygiene, some young people can show. And then also an important thing to consider is if they have a relative, a first-degree relative, a parent or a sibling who has serious mental illness, who has some kind of a psychotic disorder. So all of those things would be things that you could look for. Now, most of these things are things you could look for on the outside. So I want to show you some examples of what these young people might be experiencing inside that they may or may not be telling you about. So one is changes in how things look, feel, or sound. We can call these perceptual abnormalities, and they're kind of what you might think of as like sub-threshold hallucinations. So these can look like hearing static electricity or white noise. I even had a person saying that they kind of saw static electricity. Hearing the wind rushing by their ears. Some people say everything sounds kind of too loud or too close. They can hear everything all at once. It's really changes in the way they hear or see things, or it can even be how they feel or sense things in other ways. Another kind of category of experiences a young person might be having is odd thinking or unusual thought content. So this could be feeling like the class is watching them, thinking traffic lights have a special meaning, that their friends are pretending, teachers are against them, really kind of any increased preoccupation with ideas that most people in their community don't have. And I also mentioned disorganized communication. That's another big one. So new trouble getting their point across, new difficulty following multi-step directions. I'll read for you a couple of quotes of people who have come through the clinic or some examples that you might look for. So one is, lately, I've been having a hard time telling what was in my dream and what was real. I keep seeing blue cars. I wonder if that's a sign I should pay attention to. I think about it a lot. Sometimes I feel like my thoughts are being broadcast out loud for everyone to hear. That's why I don't leave my house. I had another example of a young person who, they live near a train track, and this train track was always there, and they maybe heard the train go by once a day or a couple times a week, and it really wasn't bothersome. And then all of a sudden in the past month, they heard it every day. It sounded like the train was right outside of their house, and they were so bothered by it, but they couldn't even sleep at night. That's changes in the way things kind of look or sound or have special meaning. So just another reminder of what this might look like in youth. And what's important to note here is beyond wanting to identify these early warning signs and intervene, these young people are already help seeking. So many of them are already in need of treatment for these concerns and coming to places like a local mental health clinic to try to figure out what is going on for them. So that experience warrants clinical attention to help them return to a life and level of functioning that they deserve and want to live. And interestingly, even though the prevalence of CHR is relatively low in the general population, somewhere around like 1.7%, it's actually much higher if you look at youth who are entering an intake for a general mental health clinic. So estimates are around, I believe the number is 19.2% of people who receive just a general mental health intake will actually meet criteria for CHR. So if you work in that setting, it's an important thing to look out for. What can you do to support a young person that you think may be at clinical high risk? So one is consider referring to crime. So usually what our referral process looks like is that the young person or someone in their life, usually a professional, will recognize a chain and they reach out to us. They can do that through a variety of methods, which I will put up here on the last slide. You can access a referral form on our website. You can call us directly. You can email us. You can also reach out to us ahead of time with any questions about whether someone might be a good fit for a referral. Then, once you provide us that information, and if the family calls us, we then provide or conduct a brief screening over telephone. This is to make sure that they're eligible for the evaluation. So we're mainly looking for a few things. One is they have to be between the ages of 12 to 30. They must have a minimum IQ of 70. And they also must have never met criteria for a psychotic disorder in their lifetime. So by definition, if they had psychosis before, they can no longer be at risk for psychosis. So then we conduct the evaluation. We have certified assessors on our team who conduct that all via telehealth, so via Zoom. It's a structured interview. We do that SIPS interview, and it takes somewhere between like 1 and 2 hours to complete. It's really an interview about their history, background, and any changes in functioning, and then specific questions about their CHR symptoms, like the ones I already mentioned. So then finally, after they complete that evaluation, they then will receive that feedback directly with their family. And then we can also provide that information back to the referrer, if you referred them, if they sign a release of information. So what happens after a young person is identified? So one thing I want to mention first is that evaluation process, even if a person doesn't receive specialized treatment after that, that evaluation can actually be a really therapeutic opportunity for young people experiencing these symptoms. So it's amazing to see when you do these evaluations, the sigh of relief that most young people show when someone starts asking them about these specific symptoms. Many of them were afraid to talk about it before or felt like no one else is going through this. And so to hear that other young people have been in their shoes can actually be comforting or validating for many young people. So beyond that, what you might do if you're working with a young person who's experiencing these symptoms, here are the important things we want to look for. If they are at clinical high risk, we want to monitor for changes in these symptoms. Are these symptoms getting worse? Is their functioning getting worse? Because that may suggest that they're starting to get closer to a first episode, or even what we call converting or developing a first episode. We can also provide follow-up evaluations if that's something that you're concerned about. Then you want to identify and reduce excess stress. So we really use a vulnerability stress model when looking at this. So really any kind of stress, even good stressors, things that seem positive, can increase these symptoms for young people. And then finally, you want to help them limit substance use as much as possible. In particular, some people, not everybody, but some people who do use things like marijuana or alcohol, we do see spikes in symptoms when they are using them. And then finally, once someone is identified at clinical high risk, they then have a couple of opportunities through our clinic. So one is they can be offered treatment through Prime. And then also there are some research opportunities that they could participate in. So treatment at Prime, what does this look like? So we have, through the Substance Abuse and Mental Health Services Administration, been allowed to offer free treatment via telehealth to youth for up to 2 years of care. We want to follow those youth usually for a full 2 years whenever possible, because research so far has suggested that those first 2 years are pretty critical in monitoring whether someone's going to develop a first episode. We do this through a step-based care model, and I'll explain kind of what that looks like. But we also offer the option of youth continuing to receive care with their referring provider while also receiving care through us. We like to think about this kind of how medical services are usually offered. So for example, all people or most people see their primary care provider for general medical services. But when a person has a heart condition, they may see a cardiologist for those specialized services in addition to seeing their primary care provider. So we like to use this model as well whenever possible. In this model, our clients may receive generalized mental health care through a primary clinician, and then they come to us specifically to address their psychosis risk symptoms. We also can just take over full care for that person, but that's up to them to decide. What does our treatment look like exactly? So I mentioned step-based care. So what we do is when somebody comes to us at the start of treatment, we conduct a very thorough assessment that helps us determine their individual risk level. They are then offered treatment based on the level of care that they require at that time, with kind of lower intensity of care if they have lower risk. So in step 1, all people who come to us receive 3 sessions of psychoeducation, in which they learn about their symptoms, how stress affects their symptoms, and they can create a plan for care moving forward. In step 2, for those young people who are at a moderate risk, either symptoms don't come down after psychoed, or if they're a little bit higher to begin with, they then received an evidence-based individual psychotherapy, something called cognitive behavioral therapy for early psychosis. And then finally, in step 3, those who are at kind of a higher risk, or they kind of remain at a high risk, even though they've gotten these other forms of treatment, we then can also offer them antipsychotic medications, and they can choose to take that or not. So beyond those offerings, we also have support style groups. We offer peer, vocational, and educational support to help the young person meet their own personal life goals. And if their symptoms do remit, they then also can participate in booster sessions that are less frequent, and then we do continued monitoring. We do a follow-up evaluation every 6 months or sooner if needed. Okay, so that is our model of care. And I'll end with some information about how the many different kinds of ways that you can make a referral to Prime. So you can call us directly, you can send a referral form through our website, and you can also feel free to contact me with any questions that may come up after this presentation. I have my phone and my email there as well.